Welcome to the Alfi Podcast, episode 16, with a very special guest, my dear friend, Dr. Michael Gelb.
Hey, David.
Thank you for coming.
Great to be here.
From New York City. For those of you who don't know, you should know Dr. Gelb is one of the pioneers in airway dentistry, founder of AAPMD, co-founder, author of Gasp, true pioneer, because you've been talking about these things we talk about now for many years, met a lot of resistance along the way, but stood your ground.
Yes.
Turns out you were right all along. Early Dr. Gelb, when this first became something you were thinking about.
We got to go back to when I was a kid.
Yep.
Growing up with my dad, and I probably watched some of those carousels. We were together in the living room going over his lectures. Wanted to hang out with my dad,
right?
Instead of going out fishing or instead of going out. I mean, we went to the Jet games together, but I kind of knew his lectures by heart, and so I got very interested in TMJ, went to meetings. I became a dentist. Never really wanted to go into dentistry to treat teeth, but I understood what I thought was centric relation. I understood jaw position.
Right.
I understood a bit about TMJ. No one was talking about sleep. No one was talking about airway. He was working with people like Witzig, and he was working with people that were doing functional appliances. But still, there was nothing about airway. And as a matter of fact, after grad school, I was at SUNY Buffalo for my master's. I taught at UMD&J, which is now Rutgers, in their TMJ residency. I didn't want anything to do with kids, and I didn't want anything to do with sleep apnea. Right. That was in 1984. So then I got to NYU in 1990, heard a lecture from Jonathan Parker and Wayne Hallstrom, and that's where I started to get an interest in sleep.
What were they talking about at the time?
You know, Parker had gotten into it. They were doing the fundamentals of sleep apnea, snoring, and it was all about oral appliances.
Right.
There was really no talk about, we knew that you could do surgery, MMA surgery.
Wasn't a great option.
It wasn't really a great option at that time. We said they would move the jaw forward 10 millimeters, 10 to 14. I don't know if they ever really got 14. But it really was about the AADSM was in its early stages. They were a stepchild of the American Academy of Sleep Medicine, and we really were like stepchildren, to them.
Was your father thinking about sleep or airway at all?
My father would go to fatigue conferences. My father would say, the people would come in and they go, we would have a Gelb during the day, and I was using a Bill Farah from Montgomery, Alabama. We were doing a pull forward appliance at night in anti-retrusion, and the patients would wake up in the morning, I feel better rested. I feel more alert.
Yeah.
I'm more focused. And my father would go to conference. He'd go, I did such a good job fixing the TMJ that I'm getting rid of fatigue. So I give my dad credit for being the first airway dentist, airway-centric dentist.
Right.
But remember, we didn't have cone beam.
Yeah.
So I went from a transcranial to a quintsectograph. I spent time with Ricketts at a Pacific Palisades.
Really?
When I graduated dental school. My father sent me to Merle Bean, his friends. And I spent 2 days with Ricketts in Pacific Palisades with his wife, Bunny. He was great. And he really was ahead of his time with airway. Yeah. Having been in Chicago and with Brody. And he had a quintsectograph. So I came back and I said, Dad, we've got to get a tomogram. Called up Arthur Quint, got a quintsectogram. But it would take me 35, 40 minutes to do a submental vertex, put it back in, develop it, trace it.
So difficult to see any anatomy, too.
It was very hard to see, but when we got the CBCT, that's like 2008.
Yep, I remember.
So it was the CBCT. My dad thought, this is fantastic because he could see the Gelb 4-7 position. He could really see things that he thought would prove that he was right. And then we developed home sleep testing.
Yeah.
So that's where it really started to crystallize. When I could see the airway, I think that just led a lot to our thinking. We still weren't thinking about nasal breathing. We were seeing that we could open the airway. We were getting 5 times, 7 times, 8 times the opening of the airway by doing mandibular advancement and holding them in this position at night.
Right.
And that's all we knew.
Yeah. And then really it was being astute and observing what was happening to patients. Because that, parallel, I didn't learn any of this either. I was doing jaw surgery, and I just started paying attention to some of these people we were advancing, and it was life-changing things that we were hearing, Their anxiety was getting better. They were less foggy. They can sleep. Their partner said they stopped snoring.
Anecdotally. Case by case.
Case by case. And it's like, one on top of the other. This person came off blood pressure medication, came off anxiety medication, came off depression medication. And if you're paying attention to these things, it becomes an obvious observation that something real is happening.
It does. And we keep putting the pieces together really as we go, right?
Yeah.
And we're learning, but still no one's really, we always had an orthodontist in the office to finish the TMJ cases. It was never, and even with my friends like Bill Hang, even with John Mew, no one was really talking, they weren't talking about airway.
Yeah.
Like Bill was fantastic. I love Bill Hang. He wasn't even using a CBCT. No one, we didn't understand, we didn't get it. Like no one knew where the disc was in the TMJ until Bill Farah and McCarty was doing arthrograms.
Right.
And that was like in the 70s.
Yeah.
So this is a really very recent field.
Yeah.
And then no one really, I was never looking at palate width.
Right.
And I think, we talk about nasal breathing. So we started talking to Guilleminot, and Guilleminot made us realize that this starts as early as the first year of life. Karen Bonnick. So in 2012, Karen Bonnick publishes a paper on mouth breathing, snoring, and sleep apnea in children. 11,000 kids over 6 years. And she points out the relationship of that to ADHD, anxiety, depression, withdrawal, shyness, lethargy.
Yeah.
And it's learning disabilities, and it's significant.
Yeah.
If they had it in the first year of life, it was so significant at 4 years and even more significant at 7 years. Even if the problem was corrected, they were still affected at age 4 and age 7.
Right.
So that blew us away. That really started to tie in the neurocognitive and neurobehavioral. And we said, holy cow, this is a lot bigger than we thought it was. And it starts in kids. And then Steve Sheldon verified that there's really, and I just heard this on Peter Attia's podcast, ADHD and anxiety are just a set of symptoms.
Absolutely.
It's made on clinic. There's no biomarker for anxiety, panic attack, or ADHD. It's based on clinical observation.
Right.
And then, but his point was, if you look at a kid who's not getting good sleep, it's exactly the same symptoms as ADHD and generalized anxiety disorder. And so that's like made us think, and we're still talking about it.
Yeah, I think that there's so much data now. Things have changed tremendously in the last 10 years. We have so much data on the sleep side of things. Like you said, we know that bad sleep is going to affect development for all these children. It's going to cause learning disabilities, personality disorders. And then as people age, we know that sleep apnea will contribute to quality of life issues, mortality. And it's not even subtle.
Correct.
It's huge. We know that even there are studies or data that show that there are more heart attacks on after daylight savings, right? 1 hour change in sleep for millions of people.
1 hour.
1 hour difference every single year will move that needle for cardiac arrest when people lose an hour of sleep. So it's like
incredible.
The data is massive and it's there. What I don't think that connection has really, you understand it, I understand it, we talk about it, but I think it's established that sleep problems cause almost every medical issue known to man, including autoimmune diseases, Alzheimer's, dementia, cardiac. I think we've established that. But what most people don't really put together is the mouth and breathing, how important that is for sleep, and probably the number one contributor to breathing problems and what down the line actual sleep problems, the root cause is going to be from the mouth,
The
and
airway.
the nose, the airway.
So I think the contribution that I made, airway-centric, Howie and I talked about it, but we kept talking about airway, airway, airway.
Mm-hmm.
And if you Google airway-centric and you look at the number of dentists, general dentists that are airway-centric, you will find some orthodontists that are airway-centric. But if you look at that airway-centric movement,
Yeah.
see, sleep was always, they thought, the purview of the physician, the pulmonologist, which was CPAP, and we could talk about that. But the physician always thought they owned sleep. The meditation people, the yogis, Buteyko, that's really breathing. But airway, which is something that you and I anatomically, that's something that the dentist, I think it's our field, it's our purview. We could start fixing it, we'd start improving it at birth with breastfeeding.
Yep.
We can do stuff in kids with appliances. And the pediatric dentist said, well, there's not enough data. So the pediatric dentists really haven't come to the table yet. The orthodontists say, well, they moved it from 11 now to 7, but even at 7, they want to refer it out to a physician. What's the physician going to do? Put the kid on CPAP?
Right.
So, the frustration is having seen this and seen it through my father's eyes, and now we're doing it, and there's a lot more younger dentists. You and I have lectured at Columbia.
Right.
We're seeing these first-year and second-year dental students, and they come up to us and they go, well, after they heard you, they wanted to be an oral surgeon.
Right.
They want to do MMA, but they're saying, I want to go into airway. I want that to be my specialty. And I think that's a wonderful thing today, because we talked about dentistry, I believe, should be a health and wellness profession.
100%. Absolutely.
It's not a reparative. To me, dentistry is not about teeth.
Absolutely.
And orthodontics, I always say, is about brain development. You got to get in there before age 7, because the brain is largely developed by age 6 or 7.
Yeah.
You need intervention from the dental community if it is a narrowed arch, if it's something to do with the mouth, if it's a mouth breather, it's a speech and language pathologist, could be an OT, maybe combined with an ENT, combined with an allergist, but you got to intervene at 2, 3, early. You agree?
Yeah, absolutely. The biggest potential for all this to make a big impact on humanity is really the pediatric dentists.
Totally, and they haven't really. They're
not there yet.
They're not there yet.
Yeah, we know we know a few that are forward thinking, but as a community, it's being missed.
I would love to see the Academy of Pediatric Dentistry get on board with it, not be afraid.
Yeah.
So the two biggest ones would be the pediatric dentist and the orthodontist, but the pediatric dentists see the kids earlier than the orthodontist. So they're really the hope, and that's where, and the pediatrician's too busy.
Right.
Earaches, trying to keep the kid alive. The kid has, the kid has an infection, croup.
Right. Completely different.
They don't have the time, to look at it. So I agree with you. It would be nice if it was the pediatric.
Or the expertise, because everything we learned in dental school really are signs and symptoms of an airway problem. Every single thing. Decay, mouth breathing.
A lot of it.
Right? A lot of it.
Crowding,
impacted teeth.
Right.
These are things that only dentists are experts in identifying.
Grinding, wear of teeth.
Yeah.
Broken teeth.
Narrow arches.
Clenching.
Yep.
Grinding teeth.
Malposition.
Teeth. Malocclusion.
Tongue ties.
Airway.
Gingival recession.
But we were never taught that at Columbia, were we?
Worn down teeth, even pediatric teeth worn down. All these things that we just, spitting off.
Right.
That dentists and pediatric dentists, orthodontists are experts in identifying are all screaming, hey, there's an airway problem.
Right. And what do they want to do? They want to fix, they think that's the problem. That's a symptom of the underlying problem, which is airway and breathing.
Right. And the problem, you're right, the problem is they're looking at these symptoms and saying, how do we fix them? Right. There's decayed teeth. How do we restore them? So then they become good at just focusing on fixing the broken teeth. There's crowded teeth. What do? We uncrowd them.
Well, we take out teeth because the arch form's too small. We have to take out teeth to fit into the small arch form. Or it's a class 2 occlusion. The maxilla's too. We got to breathe the maxilla back.
Right.
So what do? They take out 2 upper bicuspids. They camouflage it. They bring it back, and they've just created an unhealthy kid and not such a good-looking kid.
Yeah.
They've dished in the midface.
Right.
But that's done every day in the United States. Hopefully less and less, but we still see it, being treatment plan.
Yeah. Absolutely. So we're talking about really the opportunity to change someone's entire life projection into looking better, being healthier, being more successful.
Absolutely. And now that Peter Attia, Andrew Huberman, Mark Hyman, every functional medicine speaker, author, everyone's now saying that sleep,
Right.
and when we say sleep, we mean airway and breathing,
Right.
is either one or two.
Right.
You got diet, exercise, very important, but sleep has now gotten
the most important thing.
It's gotten its place at the top
Yeah.
because the other two aren't going to work out so well
Correct.
if you don't have good sleep.
And then the root cause, like we said, for almost all sleep disorders is deficient jaw growth.
Right. I mean, I think that's true, right? It's the lack of the difficulty breathing that's mostly obstructive. We know there's tone. We know there's arousal threshold. We know there's motor issues. But what you and I are doing mostly is improving the airway, the anatomy, the structure, the breathing, making room for the tongue, and then making these kids into nose breathers.
Right.
That's really been James Nestor, I think we can thank for writing the book
definitely
Breath. And we realized that you can't breathe through that nose. The advancement device is not going to work. None of your treatments are really going to work.
Right.
And so how do we make a kid into a nose breather? You know, that could be the subject. Or how do you do surgery to improve nasal breathing?
Correct.
And to bring the tongue forward? And how do you permanently? So I was doing these mandibular advancement devices for 25 years before I realized, and I saw some of Dave Singh's stuff, and I realized that even with just palatal expansion, even in a functional appliance, you could cut the HI by 50%. And then we started to hear Juan Moon, and then we started to hear about MARPI and SARPI, and now that's exploded. And now you've come on the scene, and you're really the one that I look at, and you're the one who really talks about airway, and I'm thankful for that. And I love to hear that because, you know, look, it reinforces what I've thought all along. You're the first one who's really come up with techniques where you can move the mandible forward, 15, even up to 30 millimeters.
Up to 30, 35.
Pagonion, right? Aren't you moving that forward?
Yep.
I realize now I know what I didn't know. I thought I was I thought I was transforming lives, and I was.
And you were, for sure.
But now I realize how ridiculous was it that I would think that someone would wear my device at night for 40 or 50 years. Now that I know that we can grow, now that I know that we can do surgery, now that I know that there's techniques that we can do to open up the airway,
Right.
it's changed, like you and I were saying, we've learned things every year.
Yeah.
It's changed my thinking. How do we permanently change the structure
Yeah.
to improve breathing?
Yeah. It's really exciting.
Right? Do you agree that that's
Absolutely.
been a change?
And those tools weren't there. I mean,
And also the length of the surgery. So I saw you today. You could do a surgery in an hour that used to take, 5 or 6 or more hours.
or more. Yeah.
And the healing, no, people didn't want to do it because the morbidity, the healing time, the recovery time was a lot greater.
Yeah. Yeah. I mean, the recoveries, you know, when I started doing this, it was an 8-hour operation like it is still most parts of the world. And the recoveries look so different. So different. My brother was back to work in 4 days. Which was unheard of in the traditional sense.
That's been fantastic. That's been a huge advance, I think, in our
Right.
thinking. And so I don't even know where we're going to go from here.
It's
But
exciting.
diagnostics is getting better.
Yes.
But I think we haven't talked about how many people are out there suffering with anxiety, lethargy. My number one complaint, I'd like to feel more refreshed.
Yeah.
And in our society today, you know, we've got loneliness, we've got depression, we've got people that, but if people felt better, if people slept better, if they breathed better, if they had better airways, but you know, the problem is, David, only 20% of these people that we're talking about have ever had a sleep study.
Yeah.
They haven't been diagnosed.
Yeah.
80% of them. And it starts with children, and it gets missed. Children grow up to be adolescents. Adolescents then go to high school and college.
Yep.
And then I see the kids coming with TMJ, and that's another great subject. So I'm foremost a TMJ practitioner. And what I wrote about when I wrote the article with Bill Hang about the airway-centric TMJ philosophy, what I was really saying is if we fix the airway, if we expand the maxilla, if we free up the mandible, most TMJ problems go away.
Yeah. And we've seen that here firsthand.
And would you agree with that?
100%. And my philosophy on TMJ is 180 from what I learned, and
Totally different.
Totally different. And I actually think that with very few exception, nearly all TMJ signs and symptoms and disorders are airway disorders. And when you fix those things with, whatever modality, if it's surgery or whatever it is, and get it healthy and then supplement that with myofunctional therapy, we've seen it. Hundreds of patients, their TMJs get better and their symptoms go away.
That's a revolutionary way of thinking.
Mm-hmm.
And I think it's right on. And I think all the stuff that I'm reading about, this biopsychosocial, the neuro, I think a lot of this stuff would go away. I'm not saying that you don't have 5% of cases that are neuropathic that need medication. But I think we're still talking about musculoskeletal as at least 80%. And I think of that 80, the musculoskeletal, fix the airway. It's amazing how that improves.
Yeah,
and I think that I just don't think people have seen it yet. But I think it's a fascinating concept that we've been seeing ourselves, that we're both seeing. Houston, New York, Miami, LA, we're seeing the same patients, right? It's just we treat them in a variety of ways. But because my practice has morphed into an airway practice, but I want to remind everyone, people are still coming in to me with jaw pain, clicking jaws, headaches, neck pain. And you'd probably even agree that a lot of the neck pain gets better when you do your. Do you agree that a lot of the neck pain gets better?
Yeah, we'll always ask neck pain, shoulder pain, headaches. See it all the time.
By the way, posture probably gets so much better.
Posture gets better too. I don't know if you read the book Why We Sleep by Matthew Walker.
Yeah, I love that book.
Excellent book. There was a blurb in there where he's being a little sarcastic in it, and he says, "How about if there was a drug that we were selling, and the statement for the drug."
I read about it at the beginning of the book. Yeah,
right. Yeah, he says, if you fix this, if you take this, you're going to have better concentration, mood. You're going to have better heart health.
Yes.
Live a longer life.
Look
have
better
less
in the morning,
anxiety.
less anxiety.
Look better, have less inflammation. Wow. Have better sex drive.
Right.
And the list goes on and on and on.
Yeah.
Would you even believe that someone...
Too good to be true.
Too good to be true, right? Is that even something that can be true? And the fact is that...
That's what we have.
That's what we have. Good sleep will do all these things for you.
Yeah.
Almost every ailment that man has experienced, in modern day society. Yeah. Sleep has a tremendous impact on it.
I'm with you. And one thing we talked about that I would just want to, through my work with Corricini and my work with Kevin Boyd and my work with, my father talked about Weston Price. I believe that the arches are getting smaller.
Yeah.
I'm seeing that we don't have room for the wisdom teeth like we used to. There's a lot more crowding today, more mouth breathing than we ever had before.
Absolutely.
So would you agree that our skulls are changing?
And I don't think that's controversial at all. I completely subscribe to that. I think it's a fact.
Good.
You look at skulls all across the world. It's not isolated. It's everywhere, and they have ancient skulls everywhere, and they had 32 straight teeth,
right? And
they were much wider, and their nose volumes were much larger.
The nasal airway was bigger,
and now we're not that way. Now everybody needs their wisdom teeth out. Everybody has crowded teeth. They can benefit from braces.
Everyone's using nasal sprays. Everyone's got allergies. Right. No one can breathe through their nose.
And we accept these things as normal now.
It's common.
It's
like everyone's on ADD meds. It's common.
Right. And to that point, if you accept that our jaws and airways are shrinking, which I do and you do.
I do too.
Then would it be crazy to think that alone can cause most of man's health issues?
I totally believe that. I think people don't yet give it enough credit. And I think there's so many books written about diet, but I think the trend has started changing to sleep. And every woman that I've talked to, the men all snore, but none of the women sleep through the night. There's a lot of sleep fragmentation. There's a lot of insomnia. People can't sleep anymore. And I've got to believe that we should treat the airway first, like we do with kids. So I didn't realize. I went back and I read Sheldon's book, and I read Boyd's chapter, and I read I even read like Sanjeev Kathari, and they go, before you treat ADD, before you put on any kid on medication, treat their sleep first.
100%.
We violate that rule. If you're a parent out there and you have a kid on if you haven't treated the kid's airway, give your kid the benefit. Same thing with autism.
Yeah.
You're supposed to treat the airway, give them organic food, make sure your kid's exercising, get rid of the pollution.
Yeah.
But treat the airway first, and then see the individual that you have left
get them
over.
to nasal breathe.
Right.
And look for the problems that are handicapping them from nasal breathing.
Well, the parent has to be the advocate.
Yes.
Or the spouse. You're not going to get it necessarily from your dentist. We'd like to think that you will get it from your dentist, but the public, the parent, the caregiver, the grandparent, maybe will recognize this. So everyone, could read the book Breath. You could read the book Gasp.
Yeah.
That'll have it in it, but
it's real.
We see it because we've changed.
Yeah.
We can't unsee it. Now that we've seen it, we see it.
So obvious.
We see it in almost every case, but we want people at least to get the opportunity to see what it is that we're seeing.
Yes. And you just have to ask yourself, if you have a child or a loved one that is dealing with, learning disability, ADHD, growth problems, sleep problems, and we can get into so many signs and symptoms, irritability, mood disorders, whatever it is that your loved one is dealing with, just ask the question, if there's a chance that you can nip that in the bud, make it better, and first and foremost, just look at, is there a breathing and airway problem? Is there a sleep problem?
100%. My daughter went and became a speech language pathologist. My mother was a myofunctional therapist, which I forgot to tell you about.
I didn't know that. That's amazing.
So she had studied with Danny Garliner, and so I've heard about it, but I didn't get it. Now that my daughter's with me, I'm getting it a lot more. And the reason she went into that, we were treating a boy who was bedwetting at age 13. First night with the advancement device in, he stopped bedwetting. And he didn't bedwet again. She said after she saw that boy, and she loves working with children, she goes, this is the field I have to go in.
Absolutely.
Because we made that difference. And like you and I, we believe that the dental profession, we're probably in the best place because we work with the maxilla, and I saw it today. We all work with the maxilla, what's behind the maxilla, the soft palate. We work with the mandible, what's attached to the back of the mandible, the tongue.
Right.
We're the best people to work with the tongue, the palate, the airway, the nose.
Yeah.
What's above the palate? What's above the hard palate?
It's the nasal structures.
And I saw you today opening that up. So we want everyone, we believe the dental profession, we're probably best able to affect this area, this prime area, than any other profession. We want to work with everyone else.
Right.
We're not against CPAP. We're not against I'm not against Inspire.
Right.
I love that. I'm for that. But we're trying to say, let's give every patient the benefit. And I think you and I were talking about it, and I think what you really added to the equation is the power of MMA and how easy it can be to do it and how we shouldn't be afraid of it. But we're trying to figure out for each patient, do they need MARPE? Do they need, as a kid, they need a Hyrax, they need expansion? But as an adult, that's what we're kind of coming to, is that algorithm of what's going to be best for precision medicine, personalized medicine, what's best for each patient.
Yeah, absolutely. And we have the tools now. It's just a matter of standardizing these things. I think it's going to be the next era.
I think so too. You mean with the data and looking at the analysis of each patient.
You think about all these things. We talked about turbinectomies.
Yes.
And how I think that most of these problems for the turbinates and septum is really the narrow and recessed maxilla.
100%.
And taking out the turbinates really is it's not doing patients a service, because those turbinates are there to humidify air, filter air.
Correct.
And sense air and then produce nitric oxide. So if those are removed, instead of addressing the problem of the jaw structure, now we're essentially turning those people into mouth breathers because they lose the function of the nose.
100%.
So I think we really need to start changing how we look at these things and intercept them. I think about, adenoids and tonsils in our adolescence.
Yes.
And what do you think comes first? Is it that the tonsils and adenoids cause the mouth breathing, or is it the mouth breathing that causes the enlarged lymphatic tissue?
That's great. I totally agree. Stupak had said this. I think the mouth breathing comes first, And then
I
the
believe
large
that.
tonsils and adenoids come after that.
Right. And even in these kids that have enlarged tonsils and adenoids, if you convert them into nasal breathers, will that lymphatic tissue, the tonsils and adenoids, shrink? And I think there's evidence that it does.
And that brings up the role of the speech language pathologist, the myofunctional therapist. So that may be, like Guillemin thought, establish nasal breathing.
Yes.
Get those lips together. And so we're seeing a resurgence, or we're really seeing that field getting the credit that it deserves,
Right.
because it's so important. And some of these kids have feeding issues. They have speech issues. It's the same muscles. Respiration is the same muscles. The deglutition as right. They're all the same muscles as the speaking muscles. And so we're really dealing with the same kid. And these kids all have sensory integration issues. A lot of them have motor issues. A lot of them have ADHD, learning disabilities. It's almost like, and I was listening to Peter Attia talking about autism versus ADHD versus anxiety. Our whole society, or a lot more people, maybe 1 in 3 are going to be, we're socially awkward. Intellectually, we're smart, but we can't focus. We're distracted. Are we distracted because we have the cell phone? Or did the distraction problem come first because we're not sleeping well?
Yeah.
You know, it's almost like the whole society has become having a lot of these issues. It seems like the whole society is having it. Of course, it's not 100%. But, you know, when I talk to my friend, like I talked to my friend Lane Martin, we think it's 50% of everyone in the dental chair on a given day in the hygiene room, whether it's the mother, the father, or the kid. Father's snoring, the mother's exhausted, and the kid, you know, has issues.
Where as a society, we're chronically tired. And it's, you know, a huge part of that is structural. The jaws are not letting people get good sleep, even when they get sleep.
Correct.
But then on top of that, we have a society, you know, I have 3 children. You know, we get back from, you live in New York City, you know, you live in a metropolitan city, you get back from work as a parent, it's already 7, 8 o'clock. You're going to have dinner with these kids. By the time it wind down and get them to bed, even if you're good and your kids are good at following
orders and
all that,
doing their homework,
you know, it's going to be 9, 10 o'clock before they go to bed. And then we have a society that says they got to be at school
early.
You know, you got to wake them up at 6:30 in the morning. And we don't even stop and think how detrimental just modern society is structurally for sleep.
Yeah, Rafael Pallea was trying to get this school start times to be later.
It would be tremendous.
Makes a ton of sense, doesn't it?
It makes a ton of sense. I would much rather let my kids sleep in and start school later, but focus better.
Porges says we spend our nights half awake and our days half asleep.
Yeah.
And that's really what what we've come to. So I think
we're set up for failure.
We want to prevent it, right? You and I are into prevention.
Right.
We'd love to put ourselves out of business.
Right.
We'd love to get these kids when they're younger.
Yeah.
We want to prevent these kids. We want to do a non-surgical MMA.
Right.
As a kid, we want to do the development to move that maxilla, to expand it, move it forward, right?
And that's when you can do it. That chance is there. Can do
in
it.
that critical period.
And
that's the period where we should invest in our kids, is before age 6.
Yeah.
That's where your return on investment is going to be the greatest on the kid, and give the kid the truest potential to be its fullest self, cognitively, behaviorally, and always developmentally, growth and development wise, if we intervene early.
Yeah.
So we would like to see that.
That would be huge. I don't know if you know me well enough to know that I'm a conspiracy theorist.
Okay, good.
And you know, as we're having this discussion, start to think about, you know, how big of a market sickness is.
Oh God,
in this country, right, or in this world, let's say, and how much money goes into people being sick. You know, how many people are on medicine, for everything, and how many people are living in and out of hospitals and doctors' offices and all these conditions. And if you think how restorative sleep is and the lack of it, how pathologic it is, right, or destructful it is for human health, that could there be a conspiracy that this modern society of waking people up early, working long hours, getting them on screens, late night TV shows, must see TV until 10, 11 o'clock. And at their best, they're sleeping. Take out the structural problem where they can't breathe to begin with. Even if they got a solid 8 hours, they're not getting good sleep. But now you take that poor ability to sleep because of structure and put them in a system where at best they're going to get 4, 6, 7 hours. What, you know,
It's a disaster. It's a recipe for disaster.
Yeah.
Well, I agree. The food, starting with the FDA, preservatives, Twinkies are food. 1973. So everyone gets fat. You know, when I graduated Columbia in 82, 8% of New York State was obese. Look at the eight, just 8. Now it's 35, 40%. Mm-hmm. So now you get people. Now we come up with Ozempic, the semaglutides, and now we're gonna. So between the food business, the drug business, look, I don't blame the entertainment. Look, the entertainment business is there to try to hook us all, to get us addicted to these shows. Mm-hmm. And we talked about addictiveness of certain things that are baked into the food. The Lustig talks about that. Mm-hmm. So you're 100%. Everyone wants to make. It's about making a buck.
Yeah.
So everyone wants to sell their food, and then the drug companies look at all the ads. Everything's about taking medication. That's why I love the functional medicine movement.
Right.
I love what Jeffrey Bland did.
Yeah.
I love the people that are talking about root cause medicine.
Yeah.
So you and I talk about root cause. We know the airway is root. Like, we want to get back to root cause.
Right.
We believe airway is root cause.
There's less money in saying, go to sleep early, breathe through your nose, and you'll be 100 times healthier.
Tape your lips, use nasal dilators. You want to try those hacks. Those are great.
Great.
If you can get away with it, try it. Why not? We want you to do something that doesn't cost a lot of money. Try that first. Mm-hmm. And if you need something after that, we're here to augment that.
Yeah, and if you can fix the root cause and prevent
get your kid,
taking
why not
20, 30 years of medications.
100, and I'm with you on the conspiracy part. I just say the parent, you got to intervene early to make sure your kid can breathe through their nose.
Yeah. So I do want to talk about that. Before I do, I want to hit the premolar.
Oh yeah, please.
The premolars, because at what point you went to school and learned that premolars had to be removed to fix crowding in a lot of situations. We've seen so many patients that went through the 80s and 90s as teenagers and had their premolars removed to fix crowding, and obviously that's still an ongoing thing. At what point is this what you learned? At what point was there a time where you thought this is wrong and why? And what do you think about that now?
Well, you got to remember that I grew up with a father who was talking against 4 bicuspid extractions starting in the 60s and 70s. When I joined the practice in 84, I would say that 50% of the patients coming in had their bicuspids taken out.
50.
Half the patients are bicuspid extraction patients or retraction patients. Interproximal retraction, closing spaces, agenesis, missing teeth. The orthodontic profession has been a retraction. Well, starting in 1924, let's just remember that with gnathology starting in 1924, what was centric relation? Rearmost, uppermost, push the jaw back. Gnathology was a retractive profession from 1924 when we had articulators with the gnathologists from USC. And going forward from that time until Dawson, then we had Tweed that started taking out teeth in 1945. And it wasn't until 1982 or 1985 that Dawson, Gelb and Farah were already down and forward starting in the 70s. Dawson figures it out in 82 or 85. It says, look, and Salenza had long centric, remember. Salenza noticed that when they put people back, they would come forward a millimeter or so, Right. And so he built long centric into his restorative cases. He was ahead of the game. And I'm very friendly with his son Frank and with Vinny. But in 1985, Dawson says, no, it should be anterior superior. But even though he said it, it still took another 20 years because they would say it with one mouth, but what would their hand do? 90% of the night guards that come in, David, are in retruded position, terminal hinge, 90 to 95, maybe 98. Dentistry is a retractive profession.
Yeah.
orthodontic mechanics lead to retraction.
Yep.
It's the way that the professors and the dogma, it's the arrogance that bothers me. It's not that if they would say, look, Michael, but after the lawsuit, Lyle Johnson, Gianelli, they got together and they published research showing that bicuspids were actually good for you.
Mm-hmm.
And so that's what we're still dealing with that,
Yeah.
like the tobacco industry and the sugar industry. Unfortunately, the orthodontists are not contrite. They had a Marco Island paper, which just begged the question, say, look, it's not anatomical. It's due to tone. Refer to a physician.
Yeah.
We're not part of the issue. We're not part of the solution.
Right.
Is basically
To
what they
that
said.
point real fast. I've been in academics and research my entire career. It's very easy to produce the results that you want to prove
Correct.
and put that out there.
Correct. So yeah, I think we feel the same way. We're trying to get the pediatric dentist on board. We're trying to get the orthodontist on board. There are some younger orthodontists, and there are some podcasts. There people are starting to talk about airway with orthodontics.
Right.
And I think we're starting to scratch the surface, but I'd say there's still resistance from, let's say, 80%. All the older orthodontists seem to still hold on to it.
Right.
And a resistance to what we're trying to say with airway. So I think for the public, they just have to take everything with a grain of salt. Don't let your orthodontist tell you that you need that bicuspids out.
Yeah.
We talked about the training at Columbia and how many your associate was talking about how many bicuspids he had to extract, right?
And now he feels bad looking back
Like
at
Bill
it.
Hang, he
know?
wanted to commit suicide. I mean, you feel bad. Once
Yeah.
you know what you know, you're going to realize that taking out there's another way to
Right.
do it,
Absolutely.
right?
Yeah.
So
Make
yes,
space.
I feel very strongly about that, and Bill Hang's a good friend.
I do too, and I think the message to people out there is that, if there's crowded teeth and the opinion is remove teeth, maybe get a second opinion.
Also, if your teeth are crowded when your kid is 4, there should be a nickel width between every tooth.
Yes.
If your kid has crowding when they're
That's a huge sign.
4, that's a sign. Start then.
Early.
You can call us up. You can text me. You can call me up. There will be an airway centric orthodontist. There will be someone that will intervene on your child
Yep.
in your community, and there will be a ENT that's aware of airway, but there'll only be 1 or 2. There's not going to be a bunch.
not.
And you might have to drive for half an hour, 45
But do
minutes. But do it.
Do it. Or fly.
Or fly, or go to a city where it's your kid's life that's at
Right.
stake, right?
Yeah.
So, I think early,
Yeah.
don't get a
the
second
impact,
opinion.
The impact is not trivial.
It's life changing. It's transformative, the impact
It is.
on your child, and
Yeah.
so you don't have, now that you know better, or maybe do it on your second kid or your third kid, or
Yeah.
tell a friend. But
Right.
I think it's that important.
I think yeah. So the point is, look at these things as teeth crowding as a huge sign of a problem.
That's not the problem. It's a symptom of the real problem.
Right. It's just a sign or symptom. And I think that's when I give lectures, I always say everything you learn here in dental school and dentistry, all these things, these are exactly what you said. These are not the problem. These are signs or symptoms of the problem. And there are a lot of ways to grow the jaws, even as adults.
Correct. And
with surgery and before growth is arrested, non-surgically.
Correct.
So we can always make space.
Correct. So so don't be afraid when people say it can't be done. Like all the public thinks that you can't do a palatal expander in an adult. Some of that's true, but we can assist it, right? We can do a SARPI, we can do a MARPI, you can do MMA. There are things we can do, and it's that important to do it.
It is. Yep.
Look, I'm old-fashioned. I start with a mandibular advancement device, but my awakening is this is becoming a field where we can fix the problem permanently.
Definitely.
And that's what we should be looking at.
We should be. And we lectured together at Columbia, and one of the things we both said, look, the goal here is to put our business out of business.
Right. Put ourselves out of business.
Put ourselves out of business by teaching people to do the right things, intercept early. Let's just break that down. What does that look like from age 0 to 5, 5 to 10, 10 to 20, 20 plus?
How do we do that? How do we put ourselves out of business?
Yep.
That's great. And can we just say something about Breathless, about the new docuseries? There's going to be a documentary coming out from the Airway Revolution Foundation that you all should be aware of.
Yes.
And you can go on the TARF website, the Airway Revolution Foundation, learn more about this documentary called Breathless. We're trying to figure out if it's going to come out on PBS or come out on HBO or come out on net. We don't know the distribution yet, but we think that that's going to have an impact, on awareness.
Yeah, it's a wonderful foundation. I want everybody to go check it out on their website, the Airway Revolution Foundation, TARF. They have social media.
Correct.
But definitely follow them, support them. Their mission is to bring this awareness to the masses and to education.
And that's what we need. We need more awareness because these people are not being diagnosed, right? 20% diagnosed. When I started 30 years ago, it was 15% diagnosed. So we've only moved 5% in 35 years.
We need to do a lot better.
It's not good enough.
Right.
We can do better as a profession.
Absolutely.
And I really believe that dentistry has to be about health and wellness. Dentistry, again, is not about teeth. There's a lot more to dentistry than teeth. Mm-hmm. And the dentist can really do a lot. We're really a very important part of the health and wellness team, of the functional medicine team, of the root cause team, of personalized medicine.
Yep.
So if you're going to a concierge, just because you're going to a concierge doctor doesn't mean that they're going to know about airway.
No, they're not.
Right?
No.
Even the best, they're just starting to realize, right? Even the best functional medicine doctors, how important airway and sleep is.
There are a few of them. I know a few of them that understand it or into it, but that's an exception.
For sure.
But I do feel strongly that a paradigm shift is coming, and it's upon us, where dentistry is going to solve a lot of these health issues, and it's going to start with what we're talking about today.
I'm excited about that.
Yeah,
I'm still optimistic.
I
even
am right. You should be more than ever.
I have to more than ever because I've seen the evolution. I
Yeah.
see it coming. We always thought we were there.
Right.
It gets better. Some of it gets better every year. You know, the frustration's there, but at some point, I think you and I are seeing the younger dentists being excited about airway.
Right.
And learning about airway. We have a study club in New York, the Airway Study Club.
Yeah.
There's study clubs all over the United States. So
Yeah.
whether it's LA, New York, Miami, Houston, and it's growing.
Fast.
So look out in your community. You will find an airway
Absolutely.
dentist.
And that foundation, the Airway Revolution Foundation, has resources and people there. If you're looking for providers
and
or communities.
AAPMD has provided.
Also.
There's a directory on AAPMD's website that you can look at also. So that's another place to go.
There are resources out there.
Yes.
Top pearls for the parents of the 0 to 5. Hey, what would you say? Just a few. We can't get into everything.
No. We didn't talk about it, but certainly breastfeeding.
Yes.
Look, I'm not the guy to tell a woman how long to breastfeed. Breastfeed if you can. Make sure your child is able. Noisy breathing is not normal.
Right.
Make sure your child is
lips closed.
So remember, all preemies, a preemie cannot breastfeed, suck, swallow, and breathe. They can't suck on the nipple, swallow the milk, and it's at that point the soft palate and epiglottis are locked, and they can't suck, swallow, and breathe. You have to have sophisticated reflexes to suck, swallow, and breathe, and no preemie can do that. Mm-hmm. You've got to work with an occupational therapist then to develop those reflexes so that your kid maybe can breastfeed. So there's a big difference between breastfeeding and bottle feeding, and then from there, it's working with a myofunctional therapist to develop the tone.
Yes.
To make sure that these muscles are developed so there's no speech issues. And then when speech starts, if there's a speech issue, there's very likely a motor tone. It could be a processing issue, but there might be an air. That might be the first sign to the parent, feeding, speech, that there's also an airway and breathing problem. It's very often those things go together.
Yep.
And no one's really talked about that.
That's very true.
We're very siloed. Okay, we're going to do with the OT.
Right.
Okay, now they're 2. Okay, 3. Now they're going to go to an SLP. Okay, after that, they're going to get lost.
Yep.
So I think, yes, the thing is get the right intervention. If there's questions about it, read the book Gasp, find a myofunctional therapist in your area, and just keep listening to these podcasts.
Yeah, a lot of good information coming. Age 5 to 10, biggest takeaway.
5 to 10, I think that's where you start with your expansion.
Absolutely.
So it could be MyoResearch, it could be Vivos, it could be Healthy Start. You start with these either myofunctional plants or put something fixed in.
Right.
If you have a non-compliant, put a fixed expander. That's where you're going to get the surgery that you're doing, David. That's when they can do they can do a lot.
They
reverse
can,
a lot, right? reverse
You can do it
pole
You
headgear.
can do it non-surgically at this age.
So if you
for
find
sure.
the right person, 5 to 10, that's when you start putting these orthodontic appliances in the mouth and getting a ton of expansion.
Right.
And I think that will go a long way, and you may not ever have to do braces.
Yeah. And I'm going to add to that, the tongue is such a powerful expander of the jaw, right? Probably
yes.
more effective than any synthetic appliance.
Right.
The tongue is a natural expander. So,
Correct.
something I stress to my young children every day, every moment I have a chance is make sure your lips are closed. They know. I give them a look and they're closing their lips, right? Chew with your mouth closed.
Correct.
Liquefy that food with your teeth.
And chew harder foods.
Chew harder foods. Breathe through your nose. Get that tongue up against the palate, because if you develop these habits, you have a free expander for life.
100%. And we should tell our kids lips together, teeth apart, and where to place the tongue.
Right.
That should be part of every 3-year-old, 4-year-old. Once they can listen to you, that should be something the parent is going over with the kid. And if
Absolutely.
you need
If
a
you're a
speech
parent,
language, if
yeah.
you're a parent, you should be doing that.
Doing that. Lips closed, chew with your mouth closed, stand up straight, sit up straight.
And don't give
breathe
them
through your
pureed
nose.
foods. Don't give them, like my brother-in-law was telling me, a kid has to learn how to poke through the shell. We don't want to give our kids, we want to make our kids
Correct.
work a little bit.
Yeah.
Don't give everything to your kids. Make them do the exercises.
Let's put baby food, pureed food out of business. How about
Let's
that?
get rid of that.
Let's get rid
give
of
your
that.
kids some food that they have some texture
Yep.
so the jaw expands. We
Yep.
already know the jaws are getting smaller. How do we fix that?
Right.
Solid foods earlier. There's a book called
Absolutely.
Baby-Led Weaning, which
Yes.
is a good book for parents to
So
look at.
is it Gerber? I'm
Gerber.
sorry. The Gerber Mafia. I'm sorry. Don't come after me.
No, and I know
But-
you think it's healthy to puree, but
But I'm against it. I'm
Yeah.
against the pureed food for the babies.
solid foods.
Yes.
I'm totally on board. So at
Yep.
any age, there's a lot you can do, but you've got to find the right practitioner.
Ages of 10 to 20.
Well, the girls are coming in with TMJ after puberty. So you're going to see most of your girls coming in at 14, 15.
We do see that.
Estrogen receptors in the TM joint. And so we're picking up some airway. So, the parents will know if there's lethargy. We did the pediatric sleep questionnaire, get them sleep tested, do the TMJ part. And then if they need, most of them, the orthodontics has not been, or some of them, the orthodontics has not been great. That's the time where we have a chance. We've got to get it done before they go to college. So then again, palatal expander, could be MARPE, whatever
Yeah.
they need to be able to breathe through their nose and to try to get that mandible. And so when I was talking to Stanley Liu, he says, Michael, I think the next decade is going to be the decade of the mandible. Everyone talks about the maxilla, which we know is important, but they leave the mandible, back. Right? You see cases where the overjet is 8 millimeters, 10 millimeters, right? So we finish them and we attempt to finish them. And that's what I'm doing, is bringing the jaw forward to get rid of the TMJ and to help with the airway.
Right.
So again, we're trying to get them finished before they go to college. I don't know. What are your thoughts on the ortho at that point?
Yeah, definitely. I think expansion is, maxillary expansion at that age is a huge opportunity.
Yes.
Yeah, mandible, especially these teenage girls with condylar resorption. My finding is, and I think this is consistent actually, if you go back and look at the literature, I think that the airway is a huge component of that. Obviously, it's a similar argument as the tonsils and adenoids. Is it that the resorption and mandible position made the airways worse? Or is it that the bad airways made that patient susceptible
Correct.
to condylar resorption? And I think that the airway is a big trigger for it, because even if you look at Wolfert's papers on condylar resorption, what they noticed is that you don't see it in flat-planed occlusal planes.
Just high gonial angles.
You see it in high gonial
breathers.
angles, steep plane angles, hyperdivergent profiles. So these are
Right.
patients that already have bad airways, and then they resorb. So
They've been mouth breathing for a long time.
correct. And we know that poor sleep causes autoimmune conditions to be exacerbated. And in essence, these, whether that's hormonal receptor driven or not, it's an autoimmune phenomenon that's occurring. So in my practice, we're looking at setting them up for jaw surgery, really opening up those airways, correcting what was lost phenotypically.
Correct.
in the mandible position, and we're seeing huge success. I had, recently a patient with severe rheumatoid arthritis, condylar resorption, was on methotrexate ever since surgery. It's been a year now. It's been stable off methotrexate, has no rheumatoid arthritis anymore. And then I have another patient, really bad resorption. She had psoriatic arthritis, terrible psoriasis, also on methotrexate. We fixed with a large 30 millimeter Pagonion change. Skin changed completely. Psoriasis is gone.
Amazing.
So, we see these time and time again, and it really makes me a believer that this is really just sleep and airway first.
Driving the autoimmune, driving the breakdown, driving rheumatoid, driving all this psoriatic.
Exactly.
I think that's great.
I think a really exciting area for us to get into is really for the rheumatologists and pediatric rheumatologists to be aware, because I don't think they are.
No, I think that's a big addition to the field.
Yeah. All right. And let's say, our patients, the majority of them that we see stop growing, they're 20 and above.
You get the woman come in. This is where I talk about upper airway resistance syndrome, which we haven't talked about yet. You got the thin woman. She's got narrow jaw. She's got a normal sized tongue. She's got a scalloped tongue. She's got fragmented sleep. She now gets these functional somatic syndromes. She's got irritable bowel. She's got cold hands and cold feet.
POTS.
She's got POTS.
Yep.
She's lightheaded when she gets up. She's got low blood pressure, not high blood pressure. So the opposite of she doesn't have any oxygen issues. She has sleep fragmentation. She can't breathe through her nose.
Right.
So she has airway resistance syndrome. Then we're going to open them up too. We're going to expand. We're going to do MARPI, SARPI. We may do MMA on those. But we're going to start. We're going to give them intake nasal dilators. We're going to give them mutes. We're going to open up the nose. And that's the classic thing. That's an Awaking Nightmare in Elle magazine. My patient, Rachel Comby, wrote. Give them the Guilleminot paper. Give them Avram Gold's functional somatic syndrome, so they start to understand how their bruxism, their tension headaches, their migraine headaches, all these multitude of symptoms, like you said, the unifying theory is upper airway resistance syndrome and sensitization of the nervous system. And a lot of that stuff seems to go away and get better. And these are my TMJ failures. Thin woman, fit, working out 5 times a week, no body fat. I'm exhausted in the morning. I've got headaches, and I clench every night. Right. Those were my TMJ failures.
And that neck pain, shoulder pain.
And I have neck and shoulder pain.
Right.
Those are my TMJ failures for the last 30 years. And I say we missed it. Wasn't a TMJ problem. Upper airway problem, resistance, flow limitation, narrowed airway. Yeah. Open up the airway, and a lot of those somatic syndromes get better.
Yeah, and we see this all the time. And I think this population makes up such a large percentage of our population, and these are all non-diagnosed because
they don't want to treat them. The sleep center can't treat them. They send them away.
Because they're not even diagnosed as sleep apnea. So they're put off as normal.
Correct.
But really, this is a huge percentage. And it's not so much about, we talked about oxygen and sleep. But you can maintain good oxygen but never get restorative sleep.
Correct.
Because you're fighting from obstructing.
Your brain's waking up.
But in essence, you're not getting REM sleep. You're not getting deep sleep.
Correct.
And you're not getting restorative sleep. We know that these are pivotal for healing, for memory, for creativity, for restfulness, fight fatigue. So you can think that you're asleep, and all these patients, that's what's happening. They may go to bed at one time, wake up at another, and think they're asleep, but in reality, they're never getting restorative sleep.
And a lot of them, they'll admit they have some insomnia.
Right.
Some of these. So these are missed. These are
Completely
also missed. But they're the thin women. It's not your classic phenotype of the fat man. And sometimes they go to a psychiatrist. They don't know why they're exhausted. And then they might have most of them they can be on Wellbutrin and Lexapro at the same time, because then the anxiety comes in. Yeah. But again, it's a bunch of symptoms. No one really looked at why it's happening.
And it's affecting that quality of life. And how many of these patients have their premolars removed?
Well, they all have narrow mouths.
Right.
Most of them have scalloped tongues. You're not going to cut the tongue out. You've got to make the mouth bigger.
Right.
And then the next group that I would talk about are the perimenopausal women. So half my practice is 49, 50, and 51. So we know that around menopause, perimenopause, the genioglossus, the tongue muscles stop working. Those receptors don't work as well. So that's when a woman starts to put on fat in her stomach and put on fat in her
submental area.
Yep. And that's when they become like men. Then they start to snore. Then they get sleep apnea.
Yeah.
And so again,
Yeah, that's a great point because I it's obvious that as people age, their connective tissue changes. It's more lax, right?
Their tone changes. Their
tone
connective
changes.
tissue,
So
their muscles change. Yeah.
Externally, it's obvious, right? You get jowls, you get this
Everything sags.
hanging neck, boobs drop.
Everything drops. Yeah.
Right.
The triangle of youth goes like this.
Everything
Instead
drops
of being
and
like this.
Right. And those things are
now
obvious, but what's not so obvious is that same connective tissue internally is also sagging. So
Correct.
someone that may have been okay while their tissue was taut, maintaining an airway, that threshold for collapse now is completely jumped.
But you know what I never thought of?
Yeah.
So what does the plastic surgeon do?
Neck lifts, right? Tighten it.
But they're not working inside the mouth.
It's all outside.
They're not working on the muscles and improving the tautness of those muscles. Everything is here.
Right.
You're working inside the mouth.
Right.
Getting those muscles and bringing the tongue forward.
Right.
And making it so you're not relying on the genioglossus.
That's exactly right. And
so that's interesting.
Jaw surgery really is the ultimate facelift because the structure is supporting that tissue. But just like we said, what you're seeing on the outside, you're going to see on the inside too.
The way you're doing it, though, you're improving the airway resistance. You're improving the flow limitation by opening up the the base of the nose.
Exactly.
Like we saw in your surgery earlier today.
Yeah.
So that's kind of, and then the point is the older they get, the less apt we're to do MARPI. Like in the 50s and 60s maybe, but it's going to get up there into the 70s. Like once we've done some in the 70s, because people are living till 90 to 100 now.
Right.
My goal with preventing Alzheimer's and dementia, which we haven't talked about, but that's a big part of my practice. I'm working with Dale Bredesen, Apollo Health, Richard Isaacson, Kellyanne Neotis, Peter Attia. People are sending us patients now. Can you help prevent cognitive impairment, dementia, and Alzheimer's?
And again, we know that there's a clear association between sleep and Alzheimer's.
Big time. Maybe it's the toxins. That's when the toxins get flushed out of the brain. Getting enough oxygen, obviously, above 90%. People are spending 5%, 10% of the night below 90%. We know that's not good. The brain atrophies, the hippocampus, white matter, gray matter, glial cell. I mean, there's a ton to it related to sleep and related to breathing. So the question is, at what point? We know that dementia, cognitive impairment starts 20 years before the first symptoms occur. So the question is, when should we do the MARPI? When do we do the MMA? And I would say, like a facelift, don't wait until you're 75.
Yeah.
You really want to intervene in your early 50s.
Yeah, absolutely.
Or 60s so that your brain is going to be good at 80.
Yeah.
Would you agree with that?
Absolutely.
Don't wait.
So don't wait. Sooner the better. All right. We can talk for hours.
We can talk forever.
Comment below if you want to see Dr. Gelb back in the studio. I know I do.
Love that. I would love it.
We're going to close this with my question. I don't know if you've seen this question or not, but greatest basketball player of all time in your opinion? I knew it was going to be a Nick. I know. I thought maybe you would float Patrick Ewing out there.
You thought Ewing?
He doesn't get the credit he deserves.
I mean, Willis Reed was pretty good in that last game.
Yeah.
So I'm that Dave DeBuscher, Bill Bradley.
Yep.
Bill Barton. I'm that Knicks squad from 69,
That's
72.
Great. Yeah, that's great. Appreciate you coming
Thanks
very much.
Great
we got a lot
here.
of work to do, definitely.
All right, Dave.
And a
Great
pleasure
to be with you. Thank you.
Thank you.